So today we're going to break down some of the core ideas behind lung physiology and how we manage ventilation when we are in control, especially under anesthesia. So, understanding how the lung behaves under anesthesia helps us make smarter, safer decisions for our patients. So let's start with the basics. So normally our patients breathe on their own using negative pressure. The diaphragm contracts, the chest expands, and the air is pulled in naturally. But once we give general anesthesia, especially with muscle relaxants, the spontaneous drive often disappears. So what do? We switch to positive pressure ventilation. So now, instead of the chest pulling air in, we are pushing air in using the ventilator. And that change affects a lot more than just how the air moves. First up, functional residual capacity, or FRC, it drops. Think of FRC as the lungs' emergency oxygen supply, the volume of air left in the lungs after a normal exhalation. The patient is lying flat, muscle tone in the chest and diaphragm is gone or reduced. The abdominal contents push up on the lungs, and all that leads to one thing: FRC shrinks. Smaller FRC means the lungs are closer to collapsing. Oxygen runs out faster. So atelectasis, that is collapsed alveoli, becomes much more likely. So right away, we need to be thinking about how to keep those alveoli open, often using things like PEEP or recruitment maneuvers and so on. We'll look into all that a little bit more in detail later on.